Okay, good afternoon again. I hope you have the chance a little coffee, some cookies or whatever. It's time to continue with the conference toward patient and public engagement in HTA. Now our aim, our goal is to perform a roundtable in order to figure what we are doing in the Spanish network of HTA agencies. So we'll have 4 colleagues that will come in pairs now. 2 is a coincidence, 2 men and after 2 women. But there's no room for more people here. And they will explain to us how we are working in different networks, not only the Spanish network, but we are connected with many other networks around Europe and elsewhere. It's time for the first speaker, who is my colleague in OSTEBA, in the Office for Health Technology Assessment in the Basque Country, Gaizka Benguria. He's a biologist. He's a senior researcher in HTA, working in the topic since 10 years now. So, and he has a responsibility in coordinating the emerging technologies program in the Basque Country, and is also co-coordinating, with others in the Spanish network, the so-called HTA. He will explain to you what it means. Please.
Thank you, José. Good afternoon, everybody. Buenas tardes a todos.
Good afternoon to everybody. I apologize for not speaking in English, and I'm going to speak Spanish. I thank to the interpreters. And I'm sure that the voice that is going to speak to you behind that window, it's going to be more pleasant than mine. Anyway, as I was saying, my name is José, and I'm going to speak about the advances on the methodological development lines of the agencies network that was presented before, and very specifically one of the co-protagonists, and the emerging technologies, as it was mentioned before. As you can see in the screen, it is work where the different agencies are collaborating. You can see the names of all of us, and it's me who is going to speak about it. To present you with the background and the historical line, we are going to speak where we come from, what is our way, philosophical questions that have some information to offer, the things that have been changing over time. What can we offer as a network in terms of emerging technologies? What do we need from the system and from our customers in the widest sense of the word? And what the future developments can be. In order to situate ourselves, as all of you know that we are talking about new or emerging health technologies, I think it would be interesting to establish a definition of these technologies. And it is understood internationally as techniques or procedures that are used in clinical practice that are in their previous phase to being accepted by the health system, including those technologies that are on the phase of applied research, having passed the clinical trial phase. Also, the technologies that are used in a few centers can be included in this category. This is one of the first steps of the cycle, the life cycle of the technologies that has been mentioned before. The introduction of those theoretically should be, as you can see in the slide, something simple with the development, innovation, and once the efficiency and the safety has been tested, and once the technology has been assessed, and if the decision is a positive one, then they would be directly introduced into the system. But there is a series of pressure groups, the famous stakeholders, that in some way or other can or may be involved. We should we should think that thanks to them, this technology on this procedure, etc., is going to establish a series of rules of collaboration that are different, include different actors in this system. Specifically, and regarding these sessions with reference to the patients, and as the local minister was saying before, the publicity that is done to them has an influence, positively or negatively, in this introduction of technologies. Here we find different, we can ask ourselves questions. When do we evaluate and when do we inform, and how do we inform? The introduction process from the experimental phase up to, or stage up to the development, and passing through all the phases in which the amount of information that is generated, this amount of information increases, grows in the last three phases, as you can see in the slide. And from the moment we assess this information, the quality of this information will decrease. At least the information that we need, or the one that we are going to use to take into account those technologies when it comes to accepting them and introducing them in the system. A concept that requires, that varies, that is modified, is variability. That is, when making the evaluation or the assessment, we should bear into mind that this information is really important when establishing variability. When do we have to inform and how? All throughout the process, it is necessary to have this information and to put this information at the disposal and make it available to everybody, if possible, so that this emerging technology can be assessed whether they can be introduced or not in the system according to its results. We have a series of control strategies or dissemination control strategies, the first of them being early awareness regarding the technology to be assessed, and to establish the regulation when introducing this technology with information and rules, of course, and to study the rational use of that technology. Talking about history of emerging technologies within the network of agencies, in 2006, in one of the scientific meetings of the Spanish Association for Technology and Health Techniques, or Health Technologies and Techniques, it was said that this network should have a better shape, let's say, and we have been working on the following steps. Where do we come from? Well, from this opportunity that appeared at that moment, and we have already been working in a jointly way for 11 years, and now the systems are already dealt with, and we know these technologies. The systems are, well, in the beginning they were very beginner systems, and they were working in a non-regulated way, but then we had some common working time with those systems that became little by little more experienced. They stopped being incipient systems. They became more mature. And this collaboration that was not regulated became more regulated, and we created a new capacity for staff that enabled the agencies to have more staff to encompass the different activities, and starting to be known as a network, as a referent, an international referent on these issues. As for the objectives established or set up in 2006, the first one was to know the situation of the identification and evaluation or assessment of new and emerging technology systems in the NHS, also to evaluate the current impact of its recommendations on the dissemination of some health technologies, and to establish the basis for a network of information on new and emerging health technologies in the NHS. The methodology that was used was direct contact with the Spanish HTA organizations that were having at that moment this activity through a questionnaire, a descriptive survey or questionnaire of those systems. And thus we assessed the dissemination capacity of those technologies. At that moment, there were 4 agencies that were working, or 4 systems that, assessment systems that were existing in Spain. I'm talking about 2006. So there was Detecta-T in Galicia, Sortec in the Basque Country, Synthesis in Madrid, and Detecta in Andalusia. And as for the conclusions, although there were different systems, the methodology and actions were similar. 3 of them were members of Euroscan, the international network for emerging technologies. There was a high degree of agreement on the recommendations issued. The early assessment systems modified the diffusion ratios of the technologies studied in health coverage contexts. There was a difficulty, an important difficulty in obtaining data. And as for the impact, it could be bigger or lower, depending on the degree of influence of close context without EAS. New challenges were established or set up in 2006 that dealt with improving the identification methodology. Another challenge was to be more proactive with experts. Another one was to increase information sources. Benchmarking was another one, of course. Increasing the number of experts involved, expanding the survey to other centers with information regulation systems in the NHS that were maybe not yet established as agencies or were not working exclusively on emerging technologies. Also, another challenge was to extend the experience to other communities with HTA units. And the last one, to create a stable network that adequately and timely reports to the NHS. That was in 2006. What is our current way? We are updating the early detection strategy for new and emerging health technologies of the Centex group, encompassing the different regions that work in emerging technologies. Currently, we have a web database where we share information, and we are working on updating it. It is a tool that was created in 2006, and as everything, it requires some updating, regular updating. And we are achieving, up to some extent, the fact of having harmonious and joint work. In the state work, there are some prioritization and assessment and identification, early identification of new and emerging health technologies. This is related to Paloma's presentation before. There are current actions such as the development of a functional and operating model, working model in collaboration with the General Directorate of Basic Services portfolio of the NHS, and the Cohesion Fund of the Ministry of Health, Social Policies and Equality. Also, we are using translation and the adaptation of the methodological tool created by Euroscan using Euroscan's database. And we are also adapting the pre-tech prioritization tool to be used in the prioritization of new and emerging health technologies. Also for obsolete technologies. And there is an action plan for early detection of new and emerging technologies in REDETS. Things that have changed since 2006 to our current times. Well, there is a direct interlocution with the NHS. There is an influence on the portfolio of services, as Paloma was mentioning before, with the presence in the different commissions. There has been, there is, and there will be persistence on our part. And we have improved, importantly and significantly, the methodological developments, be it search, prioritization, evaluation, format, or the grade. I suppose you are acquainted with this. As a network, what can we offer as a network? Well, we can have a common database of new and emerging health technologies. Also, we can facilitate the more efficient and exhaustive identification of technologies for the subsequent prioritization by the corresponding autonomous systems and by the Service Portfolio Directorate. And we also have a staff strategy. And we continue evaluating and assessing and improving the identification assessment system. What have we done already? We continue working on a coordinated and joint manner. We have generated a list of new and emerging technologies in 2016 with 63 entries, and we are working on more attractive formats for visualization and prioritization of the information about emerging technologies. Well, we're talking about an ophthalmoscope that can be coupled to mobile technology. What do we need from our system and from our customers? Well, we need to define a series of questions, like the basic questions that you see here. Who, for what needs, what are the priorities, what are the times, the information, and the methods, and among the future developments. We may mention the stakeholder engagement. It must not be despite, but thanks to. You understand what I mean? All of us should contribute. We should also have to test different methodologies in development, identification, prioritization, and elaboration of recommendations. We should also assess the efficiency of the system and its impact, that is, with the continuous improvement idea, and we should find new partners and customers as well. So I'm going to stop here, and I'll be ready to ask any questions you may want to ask. Thank you for your attention.
And the turn of questions will be afterwards. So now we have Jesús González Enríquez, who is a physician, epidemiologist, and very well experimented in the Ministry of Health, as well as the Agency for Health Technology Assessment of the Instituto de Salud Carlos III. He has a very long experience, and he will explain to us how to build these abilities in decision making.
So, I beg your pardon for using my mother language, and I'll try to show you the slides in English. I thank you very much to IACS and Sandra for the kind invitation, and Chafea for the financing of these sessions. Voy a presentar rápidamente
So I'm going to quickly present another initiative by the Ministry for Health, because the Ministry for Health has created a relatively new technology that is using great part of the action plan of the HTA in Spain, of the HTA network in Spain. We want to put in place one of the methods that we have to put the health technologies assessments at the core of all the policies, because we want to know the consequences of using these technologies in Spain when making a decision. And these are called monitorization studies in Spain with evidence generating techniques. So this choice we have when it comes to making decision for funding and providing with coverage with evidence generation, with new evidence generation. It's about cost effectiveness, efficiency. It is a way to handle uncertainty when new technologies get to the market when we don't have enough evidence about their consequences for the safety on certain patients. So it is a difference compared with how decisions were made in the past 20 or 30 years. In the past, public funding was used to make essays and experiments with a very large restriction for the entry of patients in the study. But it's a good choice for experimental or under research projects within the framework of CCT or registries. It is an option for the research for treatments with few or no alternatives for debilitating diseases. It also offers potential benefits when potential benefits have not been clearly demonstrated against the alternatives, and thus we need information to be able to respond to specific alternatives. So it is a coverage that is provisory while we wait for new information to strengthen the decision or to reinforce the decision. And without the coverage, it is not possible to generate new relevant evidence because there is no driver behind the generation of that information, especially in the pharmaceutical field. Many of the devices, the medical products, and many surgical or prevention interventions or diagnosis techniques have no clear promoter who wants to promote the generation of evidence that must take place before this service or product is included in the portfolio of products and services. So we assume the risks of making decisions under conditions of uncertainty, and thus two types of errors are possible. Type 1 error, it's a false positive when we cover technologies that are clinically ineffective or harmful, when patients are given the possibility to use them or to be administered with them. And the second error is the false negative, type 2 error, when we deny the access to potentially beneficial or cost-effective technologies to some patients who really need them. against or versus other, when compared with other alternatives that are chosen because they're cheaper. So we have these types of errors, and we have several types of coverage. We only have, for example, specific coverage only in research for patients involved in the research, for prospective and observational studies, restricted to the patients involved in the research because of their clinical condition or the characteristics that were defined in the study. The second type is the monitorization studies, the temporary post-introduction covering with research. It's a provisory introduction of all patients. And then we have many funding options for these alternatives, for example, coming from the industry, the private companies, or with co-payment contracts based on the results, or volume-based. So this is the graphical representation of the technologies that can be optimal for these monitorization studies. The coverage with evidence generation would be the ones located here, where the speaker is pointing to, in this shadowed area, where the expected net benefit is relevant. But at this point, there is much uncertainty, and we can reduce this uncertainty if we generate more evidence. These technologies here are partly covered. The benefit that we expect is high and the uncertainty is low, so they are good candidates for coverage. And those that are very far away from the expected net benefits, low benefits and high uncertainty are not candidates to the monitorization study and to the prioritization. What are the criteria for selecting technologies that can be included in these studies? Well, given the differences that we can find between the conditions for the approval of these technologies and their marketing, both pharmaceutical products and medical devices and surgical devices, when we have to make the decision as to whether these services and products are going to be included in the portfolio, each of them has a different evidence pool. So, due to the differences on regulatory approval and access to the market, medical devices, diagnosis, technologies, surgical procedures, and surgical implants. In Spain, there are many studies now ongoing about surgical implants. Another criterion is that we have to expect some improvement in health benefits that haven't been clearly shown compared with routine effective alternatives. The quick dissemination of this technology might offer some harmful consequences or high costs to the system. These devices or products have to be approved when they are included in the portfolio. There are some specific questions that we need to be able to respond to. In the absence of these monitorization studies, we could not generate that evidence because there is no promoter. So there is not enough activity to be able to generate that information. We also have to evaluate the feasibility and the usefulness of the study design, the value of the new evidence, if it can respond to the questions. We also have to take into account whether the benefits of generating additional evidence justify the costs, the resources and the time that we have to devote to it, and the time framework for decision making has to be adapted to the technology life cycle. We cannot make a monitorization study for 10 years if the technology cycle only covers 2 years. So this offers some advantages and disadvantages both for the decision makers in the field of health, also for the healthcare providers, for the manufacturers or products and services, and for the patients. Both for the decision maker and for the patients, having access to a technology that looks promising and that has some potential benefits in principle is good, both for the decision makers and the patients, as I was saying. But at the same time, some risks have to be taken because the decision maker might have to invest in a technology that might prove inefficient in due course. So the costs of the implementation of these products and services has to be taken into account, has to be assumed. And if the cost effectiveness is then not established, then we have to discard that product or service from the portfolio. It also has advantages for the healthcare providers, the marketers, who can receive early funding for a product that they are trying to market. So when do we start the monetization studies? In what phase? I was talking earlier about the technology cycle. So we will start them here when the research and development of the technology has been completed. Then we have the experimental phase, and then we start with the entry in the system in the private sphere. And then the dissemination starts, or the spreading starts, and then we can control the spreading of the technology with some use limitations and some quality criteria, with selected professionals and settings, and with some instructions to the patients, because the result, of course, will be a major driver for the final spread of the technology and the product. Some background. We've done some studies. We did some studies in the past with technologies that are already covered by the national security, social security and the national health system since 2002 to 2015. And most of the agencies that are now part of the agency network took part in those experiments. We did some follow-up studies, pilot studies. For example, we did some studies called monitored uses of technologies and products in the national health system. And we provided with official indications for criteria to include or exclude devices and services from the portfolio. And we recently did another experience, pre-marketing study for surgical implants, for surgical treatment for HIV-related facial lipotrophy. So these monitorization studies, as a notion, is quite recent. Only in 2015 the ministry published a ministerial order with the characteristics and the definition of the whole procedure, the protocol, who must take part in the monitorization studies, and the aims and the time frame as another option, as another alternative for assessing the fitness of new products and services to be possibly included in the portfolio when there is uncertainty about their effectiveness. The technical coordination of this study falls on the hands of the agencies of the Spanish network. They will only be applied in health settings chosen or appointed by the autonomous communities on the basis of the protocols themselves, the quality, experience, commitment protocols. Access, on the contrary, unlike all other forms of technologies, access will be granted to all users of the NHS that comply with the protocols, no matter the autonomous community where the patient lives. And the final report will be submitted to the health authority to inform on the inclusion, exclusion, or modification of use in the benefits basket of this technology. The data registry and the data collection and the analysis will enable you to make that decision and to provide the ministry with new relevant information to be able to inform on the inclusion of the technologies in the benefits basket under the current conditions, or to modify its conditions of use or their inclusion. So this is the circuit. This is the flow chart. The Commission, the CPAF, the Benefits Basket Commissions, that is the one that chooses the portfolio of services and products in Spain, is the one that triggers the whole procedure. It is a decision by the Ministry for Health, and then it goes to all the regional agencies. They have to appoint the medical centers that will take part in each of the monitorization studies, and then the data are collected and the final report is drafted. That will go back to the CPAF and the Interterritorial Council with the presence of the health representatives from each autonomous communities and where a decision will be made. The HTAs that are part of this network are responsible for the technical coordination, for coordinating the protocol consensus process, for defining the duration of the study, the criteria for inclusion, exclusion, the collection and analysis of the data, the monitorization and quality control of the data, and the reporting of the possibility of the emergence of serious adverse effects during the study, and to drafting the final report that will influence the decision making. So now we have 4 ongoing monitorization studies that were approved for the first time Each one is coordinated by one agency. For example, we have the one for biodegradable stents for the treatment of refractory or recurrent benign esophageal stenosis, another one for the reduction of persistent leak within the bronchial valve implants, percutaneous mitral valve repair with MitraClip, for severe symptomatic mitral regurgitation and heart failure, and the percutaneous left atrial appendage closure device in patients with atrial fibrillation. So these 4 surgical interventions need the use of implants. Each of them has aims, the size of the sample, which is relatively small. The follow-up is 1 to 2 years, and 8 companies that market these devices in the Spanish market take part in these studies. They also took part in the review of the protocols and have talked to the ministry to see how the provision of the devices and products will be done for the designated health centers. They have also taken part in the follow-up, and some agreements have been signed as for price, volume of the medical devices that are going to be used. The protocol elaboration, well, you know this already. There is the first phase when the agency has to draft the technology, collect evidence, collect the requests and aims of the health centers. Then there is a series of meetings for a consensus with the clinical experts, with the Ministry for Health, for the Spanish Agency of Medicinal Products and Medical Services, and the agency in charge of this study, until the final phase, the approval of the protocol, where the procedure, the methodology is described, along with the requests by the health centers, certifications, verification that the health centers comply with all the criteria in terms of experience, quality, etc., expertise, clinical training, resources, and a review by other designated clinical experts and companies, and members of the Benefits Basket Commission, which is called CPAF in Spanish, until we get to the final approval of the protocol. The Ministry for Health has made hard efforts to develop a series of protocols to record information from each monitoring study, to treat confidential data, to collect informed consent forms from patients, to define the portfolio of services, to secure access to the tool, and to design forms and statistics. There is a website that will receive the data, where the clinicians can load the data, and we have also designed the forms and the databases where the data from the patients participating in each study will be uploaded. There will be a series of authorized clinicians at each participating center. They have been granted access to the tool, and they will have to draft reports, one per year and one at the end of the experience, at the end of the study. So these 4 protocols have been approved. 27 hospitals in Spain will take part in the studies. They are located in 12 autonomous regions. The information system of monetary studies is already operational. Specific protocol databases have been designed with the tool complete, and now we are including the patients that have been selected. And finally, I have to say that it is clear that this is an option that is more and more widely used. We'll have to make more decisions when we don't have all the information that we need at hand. And so in these cases, it is true that there is more uncertainty. So this mechanism can offset part of the disadvantages, and that way we won't have to exclude patients who could otherwise benefit from these interventions. So we hope that these studies will help us confirm the intuition that these technologies are ideal for those patients' conditions. This is, of course, a long process, a costly one, with some inherent difficulties, and we have to make some progress for standardizing the procedures, the consensus procedure, the protocols, the conflicts of interests. But we have already made some big progress in the last year or 2 years since the procedure was established. We need to define the role of the companies with interest in the process, the marketing companies, and the chance they will have. And of course we have to adapt the method to the technology cycle. It cannot be a procedure that once it is approved will already be obsolete. It has to be valid when the decision is made to include it in the portfolio. I think that's all I wanted to say. Thank you for your interest.
Thank you very much, Jesús and Gaizka. Maybe can we do a few questions about these two dissertations, and afterwards we will change to another 2 others, okay? If there is any question in the floor.
Thank you for the wonderful presentations and the historical information too. So I'm from the Medical School of the University of Crete, and I'm also the HTA representative at supporting the HTA network. My question is about PRETEC, which I found very interesting. And in the first talk, I heard that you've piloted. First, you piloted internally, if I understand correctly, at OSTEBA. Then you adapted. And then you piloted last year across all the agencies. So if I understood correctly. So what I'm interested in, because Greece is about to develop its own agency, hopefully, which we have on paper for 20 years, but in practice no, is how long did it take you to actually have a prioritization mechanism in place? And I've also know you have the publication of 2006 in English. Is this the same principles in PRETEC of last year as the ones you set out in 2006? Or is there other information on PRETEC out that is accessible to us? So that's it. Thanks.
I don't know if you have checked the PRETEC web, or you know PRETEC, what it is?
But this is completely...
Yeah, it's something done with from the Galician agency, and you have it in the website. Yeah, and it's newer than it's from
2012, something like that.
Yeah. So
first web-based version.
Yeah.
Because it was already started.
So it's something in between. Yeah, in the starting of the network and now. So if you want, we can change it, check it after the.
There is material and you...
Yeah.
Yes.
Yeah.
So, may I add something? Yes. When we began with Gentech's collaboration, it was because we were already implemented some programs for identifying emerging technologies in different regions. So each of the regions had already some criteria to prioritize. When we talk each other, we saw some common criteria that could be implemented for all of us. So Galicia team took the lead to implement that in a common method, and they implement a web basis tool to help the people doing that, not only in an Excel basis, but in a web basis machine. So nowadays we have another new version because it was adapted recently last year, and it will be available in the common month or 2 months. But already the criteria and the ponderation is established. They have not changed already.
Do you pull information to link it to the second one? Do you pull epidemiological information from each of your regions?
Yes. Well, one question is the tool, as is pre-tech, to prioritize the topics. Another question is how the different regions we are identifying for all the Ministry of Health, the different topics. We do that once per year. Once a year, all the autonomous communities of the regional system, health system, identify the topics, and they put together at the ministry in the secretariat, and they, with the list, after have been filtrated, I mean, what is possible, what is not possible, is something that we can afford, and so on. This list is going back to the regions in order that each of the region is doing the pre-tech process. They are doing points, checklist with points and the ponderation, average, weight, they are weighting. Yes, sorry, my English is rusty. And after each of the 17 regions are doing that, the secretariat in the ministry, which is, the secretariat is just below you, they are putting all the points together in order to have a common prioritization. But you can consult that. Is a manual that is available on the website. And the new tool, already updated, will be available in 1 or 2 months. We can discuss later if you want. It's a very interesting topic. And it's available in English and in Spanish. And I know experiences that have been checked also in French. Do you know that? I know it. It's an, yes, they have some experience in French. I will tell you later.
Yeah.
The problems we have developed.
Yeah.
Because
right.
Yes.
Yeah, right.
the problem we have.
One question is the prioritization process.
So yes, I said that because developing such a tool and get it accepted and implemented, and this is why I asked how long did it take, 1 year, 2, 3 years, because you cannot do it, of course, in 1 year. It would be interesting if you also report, if you share lessons learned. I do not know what you will call it, what you encountered, different levels, to get it accepted or to get it established. So.
Right. Thank you.
Completely agree. One question is to prioritize, and the other, what are the topics identified and with classified in order of priority. The second is how or which are the items we will afford in the next year. But the other will maintain there, and it should be published. They are in the website.
Hola, buenas tardes. Bueno, gracias a todos.
Good afternoon. Thanks to all of you who have intervened. I am Eduardo Parra, nephrologist.
Un poco antes de las agencias de evaluación tecnológica.
Or the technological assessment agencies That is, well, why all these technologies are being assessed and approved? Because many of them have a very doubtful impact on the health of people. In my field, nephrology, I can tell that only a few have a good impact. They are approved. In many hospitals they are used, and some hospitals they are not used at all. Can anybody explain this to me, please? We will give the floor to Jose. Spanish or English?
Another is to decide. We are advising the decision. If we are asked to evaluate something, we can make advice. And the other thing is to decide. That's why you can see this variability. And the other third part is regulation. So coming into the market has some pre-requirements to become into the market. Afterwards, this is a decision. If something is in the market, should be incorporated in the public basket or not. If the decision is not taken, there could be this variability because some centers, some hospitals will adopt something which is not useful at all, and the other hospital maybe don't want to adopt it. If a decision is not taken, to me, it's a decision itself, because you are leaving variability to work themselves. No sé si te he contestado. Nosotros ayudamos a la toma de decisiones. Si se nos pregunta, intentamos ayudar a esa toma de decisiones. Normalmente estamos en esta interface entre la puesta en el mercado.
We are in this interface between marketing something and incorporating something. Then we have to decide if the decision is taken at a higher level. Normally, this tool is incorporated if the strategic decisions are not taken with micro and meso. Micro decision creates this variability. For example, hospitals, the nephrological section may adopt some of them, and in some hospitals, some other hospitals, these departments will not adopt this. Well, you say I'm not convincing you. Yes, sure. I mean, I understand the difference between he who informs and he who regulates. But why he who regulates does not understand that there is a certain degree of uncertainty when it comes to regulating? This is the right question. I agree. I know it's not a problem of the assessment or the evaluation agencies, but I think they are giving you a lot of work before deciding upon a tool or not.
Just to add a comment. We all agree with you, so I think there's no doubt there. However, what there's there is an opportunity for awareness among the clinicians that are making the decisions. I mean, we have been having these conversations within the regional ministry, at the national ministry, at every hospital. I mean, you can ask any manager. That's one of the nightmares of any manager, that actually there's no need for a decision to be made on approval for a product to actually access the clinic, the clinical rooms and be used. And in the beginning, most of the time it's for free. That's the track. That's the tricky part. And we want to experience it as clinicians, and we want to try it on our patients. And once we have tried, we don't want to give up on it. One of the points that Jesus was making when he was talking about introducing something without evidence is that some of the key questions in the monitoring studies is whether or not you can reverse the adoption. Because, you made the study and there you are. So for me, that's, I'm serious about that. I think that's a line of work that we as agencies and as a network have something to supply, to put forward, which is actually not only working hand by hand with clinicians, but providing tools for the people to be conscious of the consequences of the decisions they make.
because this variability may play wrong for the patients. It definitely plays wrong for equity in access, if it's good or it's bad, no matter which direction is really playing on that. So I think that's a line of work we need to progress on. I mean, provide with the tools for clinicians to actually make these adjustments, because I attribute them, or I want to attribute them more to ignorance and, the veil of ignorance, not knowing what happens is really good, because actually you don't need to care. So let's know what happens and we care.
So, thank you very much. Just to sum up, yo diría que el no decidir es una decisión.
I would say that not deciding is a decision in itself, and leaving it to the free will can be tricky. There is one question. Well, the two speakers have to speak. Your question, is it very much related to these two presentations? Okay, can you hold for the final round of questions? Thank you. Okay, we will give the floor now to the two speakers, and then we will again have a round of questions, a round table.
Let's go to the second part of this second roundtable. So now it's time for the women. Our colleagues coming from Galicia and Andalusia will present to us two speech. I will begin with Yolanda, which is a psychologist working also in the field of clinical practice guidelines and dealing with the interface in incorporating patients or public information into the guidelines. So please, Yolanda, go on.
Thank you very much, Jose, for your introduction, and thank you for the organizers for inviting me to present our experience in patient engagement in clinical practice guidelines. I am going to talk about our experience in mixed method research to incorporate patients in the development of clinical practice guidelines. This presentation will address three main questions. The difficulty in choosing the best strategy to patient engagement in each CPG, the advantage of mixed method research, and in particular the photo voice method. Actually, there are a broad consensus regarding the importance of involving patients in clinical practice guidelines in developing and in implementing CPGs. This involvement increases the appropriateness of clinical questions, also improves the outcomes considered in the guidelines, and the integration of patients' values and preferences. International and national also CPGs standards include the consideration of all of these aspects, but it is unclear how to achieve this. Although there are a range of methodologies and toolkits, the implementation of the optimal procedure in each guideline is unknown, and because of that, is a real challenge for CPG developers. I'm going in this presentation to explain an example of how we selected a method and how we implemented it, and a reflection about that. In 2009, the first version of the CPG, of the National Program of Depression in Childhood and Adolescence, was published. Following the methodological requirements of our national CPG program, an update of this CPG was necessary. This update was an opportunity to improve methodological aspects of the initial guidelines, specifically the strategy of patient engagement, which in the original guide was included only in the external review. After an analysis of the resources and methodologies available, the disorder, the age group, the working group decided to implement a systematic review of qualitative studies and a primary study using photo voice as a method. This was a qualitative mixed method research design that was integrated in a guideline with quantitative findings too. The qual project, the main project, was the systematic review with great circular approach. And this main project provided the core evidence basis. The qual project, the supplementary project, had a participatory design method and provided additional evidence during the main phases of the CPG and supplementary evidence to the systematic review. Photo Voice is a participatory action research strategy that involves researchers and participants in the design, procedure, analysis, and dissemination of results. Participants are considered co-researchers. It uses photography and qualitative techniques, mainly in-depth interviews and focus groups, to obtain information about the views or concerns about a population on a particular topic. Photography is the basis for discussion and promotes critical dialogue and obtains information about attitudes and beliefs. It has been used mainly in three major areas: social action, education, and health research, but there is no prior experience in the adaptation of the method in its use in patient involvement in a CPG. The main objective of the Photo Voice study was to understand the concerns, needs, and preferences of these children and adolescents with depression and their families too, using a photo voice as a tool. The specific aim was to transfer the evidence derived from the study to the CPG and disseminate the principal findings. An evaluation of the photo voice as a method was only realized. To conduct the study was necessary the incorporation of a sociologist who was an expert on the methods. Also, advice of ethical legal aspects was required, mainly to overcome challenge and ethical concerns about the use of visual data. The working group was very reviewed a lot of studies with the technique and adapted the methods and the procedures to the previous experience, and also received the approval of the institutional committee. Participants were recruited from the Child and Youth Psychiatry Unit of the main hospital in our region. A total of 7 adolescents and 10 relatives participated in the study, and all the sessions were held in the health department of the regional government in Galicia. In total, 6 sessions of 90 minutes were performed. Each session was moderated by 2 researchers, and all the sessions were recorded to analyze the narratives and the photographs of patients. In the initial session, participants were introduced to the photo voice technique, and ethical and safety uses related with the photographs was also required. The subsequent sessions were a focus group with parents only, and next 2 photo voice sessions with the photos taken by the adolescents, followed by a meeting with all the participants to discuss the main results derived by the narratives analyzed by the working group and the photographs that the adolescents taken. In the final session, 3 adolescents and 3 parents attended the working group to discuss the main clinical implications derived from the study and the recommendations. Well, the main findings in the systematic review, we selected 1 meta-synthesis and 13 primary qualitative studies. The main themes identified were how adolescents understand depression and associated symptoms, impact of depression and role of family and friends, and therapeutic approach. Findings that derived from photo voice study were integrated into these main themes and also provided additional evidence. In this slide, there are some of the main additional findings from photo voice study. First of all, the participants pointed out a demand for information suitable for adolescents, families, and the general public. Also, anti-stigma measures were important for them. They pointed out the importance of increasing social awareness of adolescent depression. Support groups were also important for them when they can share experience and information. Also, the participants pointed out the importance of screening and the role of primary care as a way into the system, the health system. Treatment it was important that treatment was adapted to individual needs, follow a holistic approach, and include psychotherapy. Also, the participants told us that it is necessary to the interaction between health and education systems. With these all results, the working group and participants together translated the main findings into 5 recommendations of clinical practice concerning experience of care and patient perspectives. This evidence also was taken into account to support and modulate recommendations on treatments that were based on quantitative findings, integrate evidence to recommendation frameworks. We also worked with the participants, with adolescents and families in the dissemination strategy. We work in a photo book, in exhibitions, in the main hospitals in our region. We made scientific dissemination, and also we consider the dissemination in mass media. Here we can see some of the photos in the photo book that was called I See My Depression Like This. As you can see, the photos are very creative and they can lead into significant dialogue. Some of these I selected we have in the photo book around 50 photos, but in total there were 100 of photos. The adolescents selected these photos, and well, there are very very beautiful finally. No? We worked with the participants in the exhibitions too. And the exhibitions were a panel, have information about the preparation for general public and the photographs. And they were installed in the main hospitals in Galicia, and also in a scientific meeting with adolescents called Galiciencia. It's regional, but there are a lot of adolescents that were there. After a lot of work for patients, for families, and for us too, we can say that this experience confirms the values of this approach for obtaining information about the needs, preferences, and concerns of patients and their families, and to translate all of that into the guide. In particular, photo voice is an effective and innovative research technique that can be suitable for its use in CPGs and HTA. It's very flexible and is really very effective, I think. And this strategy offers unique opportunities to promote citizen empowerment and, very importantly, reach policymakers. And thank you for your attention.
Thank you, Yolanda, for explaining us a method to incorporate the values and opinions of the patients or population implicated in this elaboration of the clinical practice guidelines. As a second speaker, we have Ruth. Ruth is a
hospital
pharmacist, very well, and she is coming from the health technology assessment. Is a collaborator of the health technology assessment.
Y colaboradora de la red andaluza de evaluación de tecnologías de la salud. Nos va a hablar de cómo elaborar recomendaciones para el uso correcto de las HTAs. Buenas tardes a todos.
Thank the organization for inviting us. As José said, I'm Ruth Ubago. I come from AETSA, which is the Andalusian Agency for Health Technology Assessment. And for me, it's a pleasure being here in Zaragoza. Well, I've divided my talk into 4 main topics: the background and context, the methodology, the results, and the conclusion of this methodological project, which is called Guideline for the Elaboration of Recommendations and Appropriate Use Criteria in Health Technologies. First of all, I'd like to point out some of the main objectives of the Spanish network, which are to harmonize procedures as a base for mutual recognition and quality of work, and to make those procedures and methods explicit and public, assuming a compromise with transparency and quality in health technology assessment. Well, I will say HTA. So HTA is a support to the decision-making process. It helps to move from the evidence to the recommendations. And the main steps are follow. First of all, we do an evidence synthesis by formulating a research question and summarizing the findings, mainly the efficacy, effectiveness, the safety, and sometimes also the costs. And after that, we should help our policymaker to support them to do the recommendation or the decisions. And well, as we have already said, sometimes decisions are not easy. Also, as I said before, the first step is to do the evidence synthesis. Last year, we developed a guideline for the elaboration and adaptation of rapid health technology assessment report. So next logical step was to develop a guideline for making recommendations. What do I mean by making or helping to do recommendations or decisions? For example, to help our policy makers or our clinicians to answer some question as, should this technology or this device be covered? For example, should we stop in doing screening for cancer in asymptomatic men, in all men? Well, let me highlight you some of the critical points of making recommendations. It should ensure the stakeholder involvement, and it should be an explicit and transparent process. Well, by stakeholder, I mean all the agents, policymakers, clinicians, scientific societies, and of course, patients. Well, so this year, we are developing this methodological guideline for the elaboration of recommendations and appropriate use criteria in health technologies. This project, it has a coordination group led by AETSA and AVALIA, and also a working group which is formed by all the other organizations of the National Health Network. Well, and now moving to the main results of the guideline, we've established three main kind of recommendations. Recommendations, appropriate use criteria, and recommendations for future research. For the first part of the results, recommendations, we've chosen to develop the grading of recommendations, assessment, development, and evaluation criteria, which is called the grade method. Well, when I talk about this helping to make recommendation, I'm talking about helping to inform decisions in the context of clinical recommendations, coverage decisions, or health system recommendations. As I already said, we chose to develop the grade method because it's a well-established method. It has many literature published following the grade methodology for clinical practice guideline, and currently also nowadays for coverage decision. Also, as far as we know, more than 100 organizations all over the world use or have adopted the grade principles. Also, we chose this method because of the previous experience and deliverables of the Spanish HTA reports, in which grade methodology had been followed. Well, now let me check some of the main aspects of the grade methodology. The assessment of the evidence should be made by grade methodology, and after that, all judgments of this evidence should be done. Well, recently, through the DECIDE project, the evidence to decision framework has been developed, which supports the process of moving from evidence to decision. Well, talking about this last step of making conclusions or recommendations, the panel should establish the direction and the strength of the recommendations. Well, as I said before, there are different types of decisions or recommendations, and regarding the coverage one, for example, this decision could be technology not covered, covered only in the context of research, restricted cover, or full coverage. Well, to end up with the first section, some of the key issues or the critical points or the main points of the grade criteria method is that panel composition is a very relevant step. It includes patients, or it should include patients, policymakers, clinicians, scientific societies, and also methodologists. And some of the advantages of this method is that it is consistent and transparent, and it is explicitly considered how much outcomes are valued by all the stakeholders. And some of the disadvantages are that it's a complex method and additional resources are needed. Well, now we move to the second section of the results about appropriate use criteria. What do I mean when I'm talking about this? I'm talking about criteria that are used to assess the appropriateness of medical procedures or services. I'm talking about using formal consensus techniques. There are 4 kinds of methods, and we've chosen to develop the UCLA appropriateness method. One of the reasons was that there were many experiences in our Spanish network developing these criteria. Well, as you can see in the slide, this method can be used when scientific evidence is not available or we cannot provide in-depth evidence sufficient to be applied to the wide range of patients seen in everyday clinical practice. So when we need to combine scarce scientific evidence with a formal consensus, this method might be considered. Well, you can see in the slide the main steps of the method: the synthesis of the evidence, the setting of the indications, the clinical scenarios, the definition, and the rating of the appropriateness. Let me comment you about the composition of the panel. In this case, there is a core panel which is formed by methodologists that do the synthesis of the evidence, and also there is an expert panel which is formed by clinicians who use the synthesis of the evidence and come to consensus in a 2-rounds process. And finally also comment some advantages and disadvantages of the method. And you can see, as you can see in the slide, it's a synthesis of published literature prior to consensus techniques incorporated. It allows for both confidential ratings and group discussion, which is important. Multidisciplinary panel encourages consensus from a wider group. And regarding disadvantages, it takes a great deal of time from gathering of the evidence to multiple rounds of consensus. Misclassification is suspected, and it lacks a clear rating of the evidence. Well, last but not least, let me show you 1 or 2 slides about recommendations for future research. What are these kind of recommendations? I'm referring to inform about primary biomedical research after finding evidence gaps in the published literature. To develop this 3rd section of the guideline, we follow the UNETSA methodology by using this main manual, position paper on how to best formulate research recommendations. And just to comment that we do this kind of recommendation when we find evidence gaps after developing an HTA report. So these gaps are missing evidence from a body of research that would potentially answer the question of decision makers. So final decision cannot be made until these gaps are covered. And there is a 2nd section that Jesus has already talked about it, is that in some specific circumstances, additional observational real-world data after coverage are considered. So let me read the main conclusion of our project. We have updated our methods and processes for developing recommendations and appropriate use criteria, as well as harmonizing all these procedures. So thank you very much.
Thank you, Ruth, for your brief and clear presentation. There is any question in the room? was another question before.
Good afternoon. I'm Valentina Stramiello from the European Patients Forum. I'd like to make a question to Yolanda about this innovative approach to involve patients, young patients. Do you find the whole process lengthy? Do you think that HTA agency will be ready to integrate this kind of process in the assessments? Because of what I hear from some experts working at HTA agencies, that involving patients takes time and they have to run, actually. So they cannot do that so often. So how you think you can integrate this approach? Thank you.
Thank you for the question. I think that we are ready, but there are many challenges and we have to work together with the patients to achieve this goal. The first of all is the training of all the stakeholders, and mainly the patients too. The patients have to understand the process and what the cooperation may be or should be. But I think really we are ready to do that.
Let me add that we have several experiences in incorporating patients in making assessments, but in different phases, even in the identification of the topics, collaborating in prioritization, or even performing the assessment itself, as is the case in Galicia. But there are also some other opportunities, as has been the case in clinical practice guidelines, when the patients or the associations of patients or population are also implicated. We had experience performing guidelines about giving birth or breastfeeding or diabetes 1, diabetes 2, and the patients or the associations related with breastfeeding or the professionals as well and the persons who were implicated were also giving the opinions in the time of specifying the questions to be afforded later on. Once the questions are there, it was a work of ourselves to synthesize the best evidence available. But the last phase of this evaluation was to transform the evidence into recommendations. And again, the patients and population was implicated in order to give the advice or the recommendations in the same dialect the population is using, as is the case of the breastfeeding clinical guidelines. Is the more recent one. It was this week was published, and it was in 1 week. It's a success. All the midwives and many of the pediatricians and women and so on are asking, even it's available in the website, because they were implicated from the beginning, maybe not in the mid-time of the synthesis of the evidence, but afterwards in giving advice. And I think there are new methods to implicate more and more. There was a question before.
Hola, buenas tardes. Soy Ana Mata.
Good afternoon. My name is Ana Mata, and I work for the provincial government of this province in the General Directorate of Health Assistance. I have a question for the previous panel, because Dr. González, I think that was his name, that he was talking about priority lists for new emerging technologies. So I was struck to see that in recent days, in these days, my department has received the indication to establish the priorities based on the PRITEC, based on the needs identified by the agencies in 2016. So I have a question. Do you think you are making the best use of these sheets with regards to PRITEC, because I don't see any uniformity in using the sheets. I've seen the example of OSTEBA, but the rest of the agencies use sheets that are not harmonized. Sometimes the coordination of agencies is great and it is satisfactory, but when it comes to assessing according to the PRITEC criteria, we cannot assess them. We cannot assess the sheets if we don't use the methodology. So my question is not just for Dr. González, but for the representatives of all the agencies. And I have a second question. When one sheet does not provide information or the information required for some of the criteria, how should we handle it? Shall we say it is not applicable, not available, not adequate? So my quick answer is this is the first step and we have to move forward. We have to keep on improving the methodology. We used to have some sheets and criteria, and of course this information is shared and jointly used by 17 agencies. So it is very difficult to make them all converge. So our task is to explain in a more accessible way how to use the sheets, how to use the criteria. Maybe it would take 2 or 3 years to make it harmonized, to make it homogeneous, but we need to do that. We need to do it. Sometimes it is difficult for them to interpret all the criteria, all the questions in the same way. Sometimes the interpretation is the opposite to the interpretation by another agency. So yes, we have to unify it, but after 1, 2, or 3 years, the harmonization will be complete. It also happens to us if we ask a person, what do you think? That person might not be speaking on behalf of the collectivity, but of course we cannot ask the 44 million people that we represent. We need spokespeople. We're not maybe an example to follow, but we have to do what we have to do. We have to do our homework. We have to, when the ministry will ask us for information or for opinions, we need to have done our work previously, and we have asked everyone, all the representatives in the Basque Country, all the spokespeople in the Basque Country, so that we can have as much information as possible. Because if, for example, we have a patient who says, oh, I want to have methodology to have prostate analysis or a prostate screening process. Okay, but what for? For cancer? For other diseases? For other prostate conditions? So we need to collect data and opinions. But maybe I will leave the floor to Gaizka Benguria. I agree with what Jose said. In fact, as he says, the tool is living, so it needs to be reviewed, maybe constantly. And on the other hand, it is important to know the type of information that you find that is challenging or that poses problems to you, because that helps us see the challenges and the difficulties it may pose. So it is good that you have told us whether you have difficulties in using it, because that will help us improve. So it's good for us to know that you have difficulties in rating some of the items, because it is how it is the way we can make the best use of this. A month and a half ago, there was an interregional commission. Sorry, it will take place in 1 month and a half, and I think it will be useful. It will be in a 1 month and a half. There will be the meeting of a commission will take place, and it will be useful for the harmonization of technologies. I just want to add that, of course, we're talking about two different procedures: the prioritization, pre-tech, and the second procedure is the identification and the sheets that we make to provide an answer to this identification. It is not a systematic review what you will find in the sheets. It's a series of very brief sheets with very succinct information devised to promote synergies between the both procedures. So we're still working on them, but I value your feedback. So thank you for your answer, because it's true that we are finding the difficulty. We're finding it hard to assess them because some data or many data are missing, especially for emerging ones. So we had to try and find a consensus, because even with peer review, we are scoring it differently. So I don't know whether I think we all understand it precisely, but our rating is different. Yes, but you have to take into account that these are emerging technologies, so the amount of information we can get access to is very low, is very reduced. So that's why you cannot find a lot of information, because there is not much. The information is scarce, so you cannot find. It's not our fault that you cannot find a lot of information, but however, the PRITEC thing works very well. Yes, I understand that they are emerging, and so the information is scarce, but I'd like to know whether they're going to be useful for everything, or maybe we should have different sheets for emerging technologies, for very emerging technologies, so that maybe we need some training on the scoring, because maybe we need to change the way we score it. Maybe we should make a division between the emergent technologies, or technologies that seem emergent but that are not. That's all, thanks. Any other? Yes, I thank you for your feedback, but I think there are more questions, so we have to give the microphone to someone else.
Pleasure to be here with such a learned audience and such a beautiful venue.
Can you identify yourself, please?
No. Just...
Can you identify yourself? Who you are?
Jordi Gol, Agencia de Evaluación de Tecnologías, Instituto de Salud Carlos III. Just a reminder for the younger people that they are orbiting a traditional question. I am not particularly crazy about traditions. So just remind one of the old-timers of technology assessment, I think it was Johnson, who said, it's always too early until it's too late. And he said that in the 80s, late 80s. And that was said just when OSTEBA was created at some point.
92.
I mean, this is a traditional point, and the surprising thing to me, it's another one. It's why has not been transmitted generation by generation, and why we have not been done more, particularly on the domain of health. Like industrial manufacturing, even defense, they have notions of de-risking or procedures of risk identification and fragmentation of risk and viability and things like that. These things had not migrated to the healthcare domain. To cut the story short, Technology assessment has to do with facts and truths, and to discern what's a fact, what's an evidence, so to speak, of what's propaganda or advertisement, which it's not always easy, and has been more difficult in the past. But that should be the easy part. We are supposed to advise our advisees of what to do with the state of the art. And we can do minimum forecasting, saying, well, the trend, because there is data on that, even if the thing is emerging. What's the volume? What's expected volume in some months? What will be clarified? We can do a bit more creative homework here, and we can do some more thinking. Otherwise, I will want to comment, but I won't do it now, on patients. I mean, patient is not a category like gender. And if patients have something in common, is that all of us are different from ourselves when we are sick. And to oversimplify that is dangerous. But I don't want to elaborate. And indeed, thank you, Yolanda, mental health is a very, very specific and very difficult and not friendly field. Thank you again.
Thank you.
Any other question in the room? There are two questions. First you, please. One.
Thank you. A question to Ruth. Do you have experience or recommendations for how to elaborate a recommendation for a decision to uncover or to stop reimbursing a technology, as there are so many health technologies that were covered, I don't know in Spain, but in my country I'm sure of this, when there was no strict and scientific rigorous method, but more political methods. And yet we spend fortunes on those. For these delicate, obsolete technologies, probably the elaboration of the recommendation should be different compared to the new emerging technologies. So have you experience? Or?
Well, I don't have any personal experience. As you can see, this is a new guide. I know that some colleagues of the Agencia of Canarias have published some reports, including some recommendations, but they are more clinical recommendations. Also for this 2017, we are piloting one experience. One of the projects will try to pilot this to include patients in recommendations, but we don't know if we'll reach this coverage decisions. I don't know if I don't know any previous experience about coverage decision. And coverage, I don't know any previous. Yes, sorry. Well, this is this investment.
This is this investment.
Yes, this is this investment. Sorry.
This is the so-called disinvestment of obsolete technologies. So that is related with incorporating a technology and thinking about maybe disinvest in another one. Yeah. As NHS comic said, one in, one out. No? So there are many experiences. We had some of them, and we even wrote a guide, which is the so-called GUMFT, which is available also in English and Spanish and Basque, as I know. Is the guide for non-financing technologies. It is quite well, I think, explicited criteria and how to proceed in order to compare the effectiveness, the availability, the acceptability for the patients, and so on. And there are some technologies that have been disinvested. For example, in cataract surgeries or prostate surgeries, and many others in pharmacy, as is the case with calcitonin in Spain, and some biphosphonates, and there are other, because this investment is not 100% disinvestment. It could be a percentage of exceed prescription. For example, omeprazole is one of the candidates that has been identified as being too much prescribed, and there are secondary effects. And there are several experiences, and there is bibliography about that. If you want, we can speak later on, because we have 5-10 minutes, and there is another question. I don't know if I just answered to you. Yes? We can speak later, and having a walk, even in French if you want.
Mireia Espallargas from AQUAS, who is the Catalan Health Technology Assessment in Barcelona, Catalonia. Congratulations for your nice presentations, and I have a question for Yolanda. And really, I like it, your project, your study, and I would like to know if this specific method, mixed method methodology, has been applied only for clinical practice guidelines, or to in other kind of products or products
in HTA.
HTA reports or other kind of method.
Yeah, I don't know really that this approach was applied in HTA in general, but it's a bit time consuming. I think that in a report, as usual, maybe it is difficult to implement. In a CPG, you have 1 year or 2 years for work with participants, and maybe it's more easy with photo voice.
And in the review, you perform in the review,
yeah,
where you located one method synthesis
yeah,
and different trials or studies. In which type of studies this was applied? This methodology was just for a specific...
No, in health research is applied. There are experience in health research in general about a service, but not specifically in a HTA report. I don't really know. Our revision was centered in CPGs really, but I don't remember all the previous experience, but there are experience in public health and in mental health too, specifically. But I think that the method is complicated to apply in a report, or maybe adapted maybe to the timeline of a report.
Thank you.
Any other question? Just to conclude, if I can do some considerations, just to say that this is a fruit of collaboration, just to say, among Spanish agencies, but this collaboration is taking the profit of other collaborations elsewhere. So the UNETA network has been mentioned. UNETA is working since 2004, but before that it was another project, the HTA in 2000, another project EURASES in 1996, but it was also in 92 the GENE collaboration, which is related with clinical practice guidelines, and several Spanish agencies are members of GENE. And there is another network, the so-called EuroScan, since 1997, and as Gaizka presented, 3 of the Spanish agencies are members of EuroScan, 20 years working in network, and since 1993 there is the INATA collaboration, which is a network of public agencies working on HTA. And also is a society of individual members, which is now the so-called HTA, Health Technology Assessment International. So here we're speaking about the collaboration in Spain, and I think we have advanced a lot in this spirit of collaboration, even there are many things to be done, but this is a long run that we have observed. Myself since 1992, 25 years working on that, allows to me to have this, as Jordi has mentioned, this perspective from the long run in this topic. And maybe we can analyze that. We have advanced, but we have many other things to improve in our methods, in our collaboration, in incorporating other voices from stakeholders, from industry, to patients, to associations, population, and so on. So thank you for 4 speakers for this roundtable, and I hope you have enjoyed or learned or share ideas with us. Thank you very much. We'll see you here tomorrow morning.